Dr. Tofi. Welcome to Hernia Talk Live. We're here every Tuesday with a special guest. Today's special guest is Dr. Todd Ponsky. He is a pediatric surgeon, and I am willing to wager a lot of money that he is our top hernia specialist in the United States, possibly the world. He practices out of Cincinnati, Ohio, at Cincinnati Children's Hospital, as well as Akron's Children's Hospital in Ohio. And he's coming to us live. Dr. Ponsky,
Good
how
morning,
are you?
good afternoon, good evening, whatever time it is.
Thanks for coming and thanks for donating your time to this. Those of you who don't know Dr. Ponsky, you may be the only pediatric surgeon that I know of that is in our hernia world. We have like what we call hernia friends. We call each other hernia nerds. And we have, annual hernia meetings, both in the United States and elsewhere, in both the American Hernia Society, SAGES, etc. And you're really the only one I know of who specializes in children that actually talks to us.
We have
Is
to
that
get
about
more.
right?
Yeah, we have to get more up there.
I know. Well, I must say I do enjoy it. We've actually debated together. I was forced to debate against you. I think no one else wanted to debate against you because it was fun. I enjoyed that. I think was that last year?
It might have been last year or 2 years ago.
Year.
You definitely won.
Oh no, I don't think I won, but I tried. I tried very hard. If it comes on YouTube, I may have to delete it.
It was a good debate.
So maybe you can tell our audience a little bit about how you got into hernias in the pediatric surgery realm.
Sure. So hernias in children is one of the most common operations that we do in children, that and appendicitis. And when I say hernias, there's two types that kids get. Well, there's three: inguinal hernias in the groin,
right,
umbilical hernias in the belly button, and then the epigastric hernias up in the top of the abdomen. And so every pediatric surgeon is a hernia specialist. I became interested because we started doing research on it and trying to understand what's the best way to do this. And we started exploring how we can do it less invasively. And when I say less invasive, the operation's already small incision, but we wanted to figure out if there was a way, especially in the tiny neonates, the newborns, who's the most common baby that we operate on with a hernia. It's the structures there are very, very fragile. And so we wanted to see if we could do it with a way without manipulating the structures. And so I learned, flew out to California actually, and learned how to do a laparoscopic repair from a surgeon named Craig Albanese. And then since then, we've modified the repair based on a Japanese approach. And they've been doing research on it for years, and the rest is history.
Yeah, I feel that hernias are so common that people who do research tend to focus on rare diseases, the really cool diseases, and so hernia advancement has not really been something that people aim to do. But those that do make such an enormous difference, because in adults we're doing 1 million hernia repairs a year in the United States alone. I don't think that includes pediatric. I think that's only the adult data. So if it's the #1 hernia repair for children as well, you can just probably 1 point something million a year.
Right. That's probably about right, because it's several 100,000.
Yeah, that's pretty crazy. Now, when you do the hernia repairs for the belly button, do you use absorbable or permanent suture? What's the standard?
Right. So it depends. We use sometimes a permanent suture, an ethibond or a braided stitch. Some surgeons will use a vicryl suture, which is a dissolvable stitch.
That dissolves in 3 weeks.
So we studied that, and we found out the hard way that that's the time that's as long as you could trust it. But when we studied it, it actually took several months for the vicryl to go away, because we kept going back in the research model, and they were still there. But yes, it doesn't last long.
And is that adequate? Because
Yeah, that's why. So I use a permanent suture for that reason, and I think that some in the tiny little babies, theoretically, there's the skin is so close to the hernia that it could have a reaction. But we really don't fix the belly buttons in the little babies, so that's why most of us would end up using a permanent suture.
So one of the reasons why you don't fix the belly button hernias is because they close, right?
They go away. 80% of the time, a belly button hernia will go away by the time the child is 3 to 5 years of age. So we usually wait till they're 3 to 5, depends on the surgeon. We just did a study that found out the mean age is 4. And we also, we did a study and another person repeated it that showed if you do it under the age of 3, they have a higher chance of coming back again. So
Oh,
4 is really that sweet spot, 4 or
is that because
5
they're
years.
crying all the time?
I think the integrity of the
A lot
muscle
of
is good.
pressure.
There's probably a lot of pressure. It's true. And so it's just usually end up using a smaller stitch. But for that reason, most of us wait. The other thing that's huge is that there was a new body of research that's been coming out
Yeah.
that's been showing that there may be some long-term deleterious effects of anesthesia in babies under the age of 2. So we really have had a massive switch in pediatric surgery where unless it's urgent, we try not to do any surgery under an age of 2 or 3 is actually at our hospital.
Mm-hmm.
So that's another reason to wait on those.
Yeah, our pediatric surgeons mentioned that too, is that most of them close, but also you don't want to do surgery in like 2 or less unless it's really urgent. So do you get kids where the hernia incarcerates or causes an emergency during those watchful waiting years?
That's a fantastic question. So the incidence of an incarceration where the intestines get stuck in the hernia is probably less than 2%. So we almost never see it in kids. And for that reason, we feel very safe waiting. Now, groin hernias is a different story.
Yeah.
But the umbilical hernias, the incarceration rate or the chances of a problem happening while you're waiting to do the repair is incredibly low.
Okay, so babies up to age 3 to 5, you kind of wait for their belly button hernias to close. If they don't close, you operate in the 3 to 5 range, usually with stitches, usually with some type of permanent stitch, right?
Correct. Now, some people would say, you know what? What if you just leave it alone? Why do you need to fix it? It's a small little hole, so what? Well, I don't have the answer to that. I'll tell you my theory, and I'm curious what your response is to this. My theory is twofold. Number one, for a child to have an umbilical hernia repair, it's basically 4 stitches and you're done. They go home, they're out playing the next day. If you don't repair it, and a problem does happen when they're older and the hernia defect grows, you may have to use a mesh material, which could be a more complicated operation. So
Right.
I believe the reason to do it is that it's just so easy and it's so safe that why not fix it?
Yeah.
So another thing that some people do is they do it by gender. So if it's a female and there's a high incidence that it's a tiny little defect, but it grows during pregnancy, that might be a reason to fix it when they're younger as well. I don't have a gender difference. I do it in any gender, but that's what some people say.
That's interesting. And then we'll get to the mesh question later because we already have some questions on Facebook Live about mesh, which we'll get to shortly. So groin hernia is different, right? Those don't close, correct?
However,
Or do they?
so the thinking historically forever is no, that they don't close. Now you're getting me started because this is my whole body of research. So
I know.
But I will say that the thinking, so there's 2 things about a baby hernia. Most present as a newborn.
Correct.
The chance of it getting stuck as a newborn is 30% if they're premature. That means 1 out of 3 babies that have an inguinal hernia as a newborn, that's a premature baby, will have an incarceration. So for that reason, we fix those relatively quickly because we don't want them to get stuck. Now there's that balancing act of trying to get them a little older so they don't have to go into surgery at such a premature age.
Right.
So we oftentimes will watch them very carefully and get them to that point to fix the hernia. Once they get over a certain age, about 1 year of age, that incarceration rate starts to really drop to the same level as adulthood, which is really low.
Yeah, it's very low.
So it's less than 1%. So in a newborn, we do fix them. Some people think that, as I do, that I've thought forever, is that they don't close and you need to fix them. But we do have one patient that we just presented, I forgot which meeting we presented it at, that we had an image where we were doing an appendix operation and we saw a hole. We didn't fix it because it wasn't symptomatic and it was a dirty operation. And the patient went back with groin pain years later, 5 years later, and it was gone. So maybe they do go away.
So the thoughts of with the premature babies, is it that the hole hasn't had a chance to close yet because they were born or too early, or is it that they have an intrinsic collagen deficit or defect because of their prematurity?
We don't know, but we do believe it, that the process of so what happens in a baby is that the testicles or the ovaries start off in the abdomen, high up in the abdomen.
Okay.
And during the third trimester, towards the end of gestation, they drop down into the pelvis. So the girls, the ovaries drop down into the pelvis. The boys, the testicles drop down into the pelvis, but they keep going and they go outside of the abdomen and a little canal is made between the muscle. So there's no hole in the muscle, but the muscle sort of part like the Red Sea. And
right.
The testicles find their way down into the groin.
Yeah.
And that path, that little tunnel that was made, usually closes right behind them after they get down. And what happens when this goes awry, often because they may have been born early, that never had time to close behind them.
Okay.
So now there's that canal that remains. And so other things in the abdomen can follow that canal, like the intestines. So that's the thinking of why it happens.
And for groin hernias, you perform both open and also laparoscopic repairs without mesh,
Yes.
Which is something that we're not taught as adults to do. But how was your research going on with the outcomes of the laparoscopic non-mesh repair?
Great question. So when you say what's happening now is, we used to call it, when you say laparoscopic hernia repair, there's like 10 versions of that now. So it's hard to study because everyone does a different technique. What is emerging as probably becoming the most popular technique is a way that we do it where we look inside with a camera, but we do the operation actually from the outside with a little needle poking in and coming out.
Right.
And we studied that multiple ways. So many studies have shown the recurrence rate, which is our big measure of did it work, is how often does it come back again,
Right.
Is less than 1%. And multiple studies. Now, the original laparoscopic hernia repair had like a 3 or 4% recurrence rate, but we don't do it that way anymore. We've learned a lot of tricks through research about really impressive techniques to add to make it stay together much better.
Cool.
And with much less pain. And it's less than 1%. The second thing we did is, well, I'll stop there because we did also study this in adolescents too. But for at least all comers, it's the same as the open repair, which is less than 1%. So
for either the belly button or the groin hernia repairs, if it comes back, I know it's low, but 1% of a big number is still a fair number. So if it comes back, then, and they're still children, and we know we don't like to put mesh in children because mesh doesn't stretch and it's a foreign body, and kids are in the growth stages, and you don't really want to kind of do something unnecessary at that stage. What do you do with a recurrent hernia?
Big difference between the adults and the kids, that the pediatric operation. So here's the biggest point I can say tonight is that a baby hernia is very different than an adult hernia.
Correct.
So A baby hernia is
That's what I
not
hear.
right. So it's not a problem with the muscle. The muscle is totally normal.
Mhm.
It's that little path that went between them stayed
Mhm.
open. And so all you need to do is remove that thin layer of material that went between the muscles, that thin tissue
Mhm.
called peritoneum. You need to just remove that,
Right.
and the muscles close again. So the reason I'm telling you that is that the operation, if it fails, something went wrong. It's
Right.
hard to know what it was. Maybe not all of it was removed, or maybe the stitch fell out. But unlike the adults, it's very easy to fix again. And so the chances of it failing twice, I guess, would be really, really low, because the chances of it failing once is less than 1%.
Got it.
Chances of it failing twice. So unless the baby has some sort of connective tissue disorder, uh, almost all the surgeons I know would just go back and do it again. And probably laparoscopically, because that's your best way to approach something that's already been operated on,
Right.
in my yeah.
Okay. So that's a legitimate practice, and the outcome is expected to be good if you just redo it with a tissue repair, whatever that repair is.
Yes.
What even for belly button hernias?
So it's even excessively more rare than much more rare than even an inguinal. An
Oh,
umbilical hernia repair must mean that a stitch popped out,
got it.
because it's a stitch broke, or a knot came untied or something, and all you have to do is go back in
Yeah.
and put another stitch in. It's a
And
it's a
you don't have to deal with like smoking and alcoholism and
correct,
obesity, diabetes. That's not usually something you have to deal with, which are all
right.
risk factors for hernia complications.
That's why I went into pediatric surgery.
Right? You have to deal with the parents, which I'm sure is not
That's
easy.
true.
Okay, we have some pre-prepared questions from before. Let
Okay.
me let me go through this real quick. You've answered a lot of the questions already. This is great.
Good.
Okay, what ages do you treat inguinal hernias? I guess all ages. You already
So
answered that question.
obviously
But
the
what do
early
you treat? I should say maybe that's the questions. What ages do you treat? Like how
right.
high up do you go?
That's the question, right? Because obviously we'll do any young age. The question is, what age do we stop doing them?
Right.
So once I get to an adolescent, it becomes quite controversial, because the adult surgeons and the pediatric surgeons do quite different operations for a hernia.
That's
As I
true.
told you, a pediatric surgeon just removes that tissue. An adult surgeon, most of the time, does either a repair, they repair the muscle, either with suture material or with mesh material. And so is an adolescent more like a child or more like an adult? And that's what a lot of our research has been focusing on. And we've taken some roundabout ways of trying to figure that out.
Mm-hmm.
And here's what I have a very long discussion with the family, because there's no one answer. Here's what I say. My answer is that, as I explained before, a pediatric hernia repair has an incredibly high success rate. We studied this in the adolescent population, and it's less than 2% for all comers of an open repair, and the laparoscopic repair is about the same exact thing. It's about
Which
2 to
means 98% do not need another surgery.
right. However, I'm going to tell you my own flaw of our research is that I don't follow them their entire lifetime, right? So
Mm.
we do a 5-year follow-up. Does it recur 20 years later? Maybe. We don't know that. That's a much harder thing to find out. But at least 5 years out, which covers most recurrences happen early after surgery, we think that it at least shows that it's a pretty good operation. That operation is very simple. It's just a stitch. It's not putting mesh in. And so what I tell parents is there's two choices. I can send you to my very talented, good adult colleagues and talk to them. And I oftentimes will give them a number, have them meet both of us, and they can decide, because there's no one answer. I recommend doing the laparoscopic non-mesh repair, because if it fails, which is incredibly rare, they can then go to have an adult surgeon put in a more permanent type of repair.
That's right. There's been no burn bridges, for
Right.
sure. Yeah. Well, I'll tell you, as an adult hernia surgeon, almost all my practice is revisional, and I do get some patients that have had a hernia repair as a child, but I'll tell you the typical scenario is they were born with a hernia, a groin hernia, and so they had their repair, as an infant, maybe up to a year old, and then they'll see me at age like 40 or 50, and they'll have a hernia. So I can't really even say it's a recurrence from the childhood repair. It's just probably an adult hernia now of some sort. In other words, they're
Yep.
not coming to me at age 19 or 20
Yeah.
saying, that sucker that operated on me 2 years ago because I was pediatric recurrent. That I don't see that. That doesn't happen.
That's the main question. The Mayo Clinic
Yeah.
did a 50-year follow-up study, and they said that most of the very small number at 50-year follow-up had a reoperation, but those that did had a direct hernia, which is an adult type of hernia. So it's possible
Yeah.
that it's a new hernia.
Do you see directs in children?
I have only seen one. I've been in it for 20 years. I've only seen one, and it was uh, from a patient that had been operated on by another pediatric surgeon, and they did it. I think it was caused from the surgery, which can happen.
Oh,
So the main one of the other main reasons we do it laparoscopic is that can't happen because with the open repair you have to get in there and lift things up, and sometimes that can cause an injury to the very thin floor, which causes
true.
hernia. And if you make that injury in a baby, it's just a couple cell layers,
Yeah.
they can get a direct hernia. So with laparoscopic, we don't mess with that at all. We just put a stitch in. And so we think that we will be long-term having a lower recurrence rate for that reason.
And just to be clear, the tissue repair, you're doing the laparoscopic, but in the open tissue repair for children, it's not like a Schuldeis or Bassini. It's more of what we call a Marcy. You just close the hole, correct?
So if you're saying for a direct hernia or an open
Just a
indirect.
child with an open
Yeah.
indirect. Yeah.
No, yeah, it's at Marcy at most. So
At
it's
most.
usually a high ligation. So all you do
Oh,
is find just that little bit of tissue that went along. You find it, you tie it off at where it starts, and you remove the excess tissue, and that's it. That's what 90% of people do. Sometimes if you see that there's also a little weakness in the muscle, you put one stitch. That's called the Marcy.
yeah.
But that's unusual. Most people just do a high ligation, which means they just stitch it.
Oh, okay, cool.
Yeah.
Another question that came in is you mentioned braided stitches. There's this thought that braided stitches cause a higher likelihood of stitch abscess or mesh or stitch infection, wound problems. Do you notice that? Is that an issue?
Yeah, so it's very, very unusual. What does happen is if you put in a braided suture in in something that's close to the skin. So if I were to do an open hernia repair, and in inguinal hernia repair, and I used a permanent stitch like a silk, they cause sometimes a reaction and get an infection or an abscess. And
Right.
so for that reason, most people use a dissolvable stitch when they do it open. And so the laparoscopic, it shouldn't happen because they're all under the inside the abdomen, but it is certainly possible.
Interesting. The other question that we have, which is, I think, a very good question, insightful, is does my child's hernia need to be repaired by a pediatric surgeon?
I would say this is controversial.
Okay.
Here's how I would answer that. Of course, my answer would be yes. I think that this is all we do. This is what we're trained to do. So my answer would be yes. However, there are some incredibly talented adult surgeons that do a lot of pediatric hernias. So if it's someone who has a great deal of experience in pediatric hernias and that's all that's in your community is an adult surgeon, then I would say, that's probably okay. I think if it's an adult surgeon who does mostly adults, they're probably not that used to the pediatric anatomy. So I would recommend a pediatric surgeon, and also then you get the benefit of a pediatric anesthesiologist. So
Right.
For that reason, we do recommend that. Yeah.
Yeah, that's a good point. We have an anesthesia question here too. Here it is. Is anesthesia safe for children?
So the answer is this. Here's the general thing. The incidence of a problem from anesthesia from a child is less than your chance of getting struck by lightning. It is incredibly low. The actual number is that they say that your chance of getting hit by a car walking down the street is greater than your chance of having a mortality from anesthesia.
I mean, in
However,
LA, we get hit by cars all the time.
that's true. It depends what city.
That's a
Yeah,
bad one.
yeah, that's true. Um, However, here is what's emerging, and this is unclear and it's just starting to emerge, is this question that is not totally answered, but it was published in the New England Journal, that there is a theory that if you have multiple operations, multiple anesthetics in a baby that is under 2 years of age, there may be some neurodevelopmental things that you may notice in adulthood. It is not really clear. They're actually going to refute that paper soon. So we just don't know. It's such a hard thing to study. But for that reason, because we don't know, the new policy for most pediatric surgeons in the United States is to not do an elective operation until they're 2 or 3 years of age, unless it's urgent.
Got it. That makes sense. Tell me a little bit about your practice. Is it mostly hernias, or is it like half hernias, or it's just that's your
I
interest?
would say, so that's a good question. I would say it's not half. So a pediatric surgeon is an interesting job because we do a little bit of everything.
Yeah.
So a pediatric surgeon is your pediatric thoracic surgeon. A pediatric surgeon is your neck surgeon, your abdomen surgeon, you're even your pediatric gynecologist, and you're sometimes even doing urology and other things. So we kind of do a little bit of everything. Plus, we do a lot of trauma. So
Oh,
pediatric surgeons probably spend the majority of their time doing those types of things, appendectomies and urgent things.
yeah.
We do a lot of neonatal congenital surgery, babies that are born with something wrong. Electively, without a doubt, the most common thing we do on an elective basis is a hernia, umbilical and inguinal.
Yeah. There's a two-part question. One is, do kids get incisional hernias?
They do. They do. In fact, we do different types of incisions on babies because the most common type of incisional hernia is in the abdomen when you do what's called a midline incision, so straight up and down. And in children, that because the muscles aren't that strong and formed yet, they can have a higher rate of incisional hernias sometimes than even adults.
Yeah.
So in the tiny babies, we usually
Oh,
make our incisions going the other direction, going
yes.
across the abdomen, because it has a lower rate of an incisional hernia. But absolutely, babies can get them.
Well, in adults, it's still true. The midline up and down incision has a higher hernia rate than the left to right transverse incisions. That's why C-sections, fan and steel incisions have a very low rate of incisional hernias. And in a lot of other countries outside the US, Latin countries, Middle Eastern countries, they go paramedian. So it's not exactly midline, it's just to the side of the midline, up and down. And those have less hernia recurrences too. We kind of don't do that in the US. I think it's more of a cosmetic issue. It's a cultural issue. I don't know. We definitely don't go left to right very often, but even in adults, it's a better incision, mostly because of, based on an incisional hernia. So if you get an incisional hernia, what do you do? How do you repair those?
Again, so I'll give you just, anecdotal. A lot, it depends on their age, but because they're usually pretty small, we usually will fix those primarily first, unlike adults where you place mesh. Now, the reason that we don't like putting mesh, why do we keep trying to avoid mesh?
Yeah, let's talk about that.
So the reason is that children are still growing. So if you place a piece of mesh over an area, depending on what age the child is and how fast and how much more growth they have, it will get distorted, moved off to the side. It won't be in the same location and it won't cover the area. So things grow with the child, right? So if you have an incision that's this big, it becomes this big when they grow because everything grows together. So would the defect. So for that reason, we try not to rely on a mesh in children. Now, the reason, this gets really controversial, but the reason we don't like mesh in the groin in children, the reason we don't like that is severalfold. Number one, we're very lucky that the pediatric primary repair, just doing a high ligation, has a less than 1% recurrence rate. It works really, really well. There's no reason to put
Right.
mesh.
Right.
And even up to adolescents. And we haven't studied adults in this, but at least up to adolescents. So,
I have a population if you want to get into that.
well, I'm going to call up on you on that because we started a pilot in Norway, and when that they've done quite a few and in adults and seen very low recurrences. I don't even think they've seen one yet, but I think that's the next step I'll get to. First, I have to work on the adolescents, but when you're operating on a child, besides the fact that you don't need mesh, putting mesh in a person that hasn't been through their fertile years yet, it theoretically could injure the spermatic cord, which
Yes.
carries the sperm. So if someone's past having kids, it's not an issue. But if it's someone who's going to want to have kids, I get afraid to put because the way the mesh works, and maybe I'm wrong, but my understanding is that it causes a scarring. And so as it creates a scaffolding. And so if that's true, it probably could involve the cord in that. And so that's our fear of why we don't like to put mesh in the bilateral, both groins of a child.
Yes, so that's true. There's a controversy in adults whether having a hernia repair with mesh affects your fertility. And the most modern studies say no, it does not. There was some really cool study done in, I want to say Brazil, but somewhere in South America, where they wrapped the spermatic cord with the peritoneum from the hernia sac to prevent it from getting stuck to the mesh. And then they did pre and post sperm studies, not fertility necessarily, but sperm studies. And there was a dramatic difference. The people with synthetic mesh had a lower sperm count than those that protected the spermatic cord from the mesh. I do treat a lot of people, as you know, with mesh-related complications, and one of the complications can be erosion of the mesh into the spermatic cord, including the vas. Usually it's just testicular pain, but there's a handful of male fertility specialists around town who I work with, and they have to do like a revision of the vas because the mesh eroded and the patient has having fertility issues. It's like a vasectomy reversal almost, except the vasectomy was functional, done by the mesh as opposed to like a vasectomy done on purpose. Very, very uncommon, fortunately, but the risk is for sure there, and I think you're right. I'll give you my personal thought on this because I do take out a lot of mesh, but I understand that mesh is so useful in the adults, specifically for big abdominal wall hernias. Like that's virtually impossible to do a good job without really maiming the patient. But in the groin, we have a lot of options. In the US, the knee-jerk reaction is to put mesh in there, but we do have a lot of options. So, when you do your laparoscopic non-mesh, I came up with a laparoscopic or robotic non-mesh for adults, but I only limited it to really small hernias. So it's more like the pediatric hernia where the inguinal canal is pretty much preserved. It's just there's content in it now, as opposed to a gaping hole where it's straight through. You kind of maintain that anatomy still, and they're symptomatic. And so those people do very well with just closing the defect. And again, like you said, if they fail, then they can move on to something more advanced, but you haven't burned any bridges in doing a tissue repair laparoscopically or robotically with those. But the reason why I said I have the population is I have a lot, relative to most surgeons, I have a lot of people with small hernias that are symptomatic and what we call occult hernias that people don't think are hernias because it's not some big old huge defect, but they're symptomatic, and those may be the perfect initial population to pilot your study in adults because they really don't have a disruptive inguinal canal. It's just a normal inguinal canal with a little bit of fat stuck in it. In which case, if you remove that fat plug and close off the peritoneal defect or whatever your technique would entail may work.
That's
I
a
think
very
we
good.
just need more. We need to do more. We can't just say, oh, well, what we have is enough. In fact, I posted on our group that, hey, I came up with this like great robotic option for non-mesh repair. And everyone was like, I mean, we already have all these repairs. Like, I'm like, yeah, but we don't have a laparoscopic non-mesh repair.
Right.
It's all open. And they
Yeah,
kind of looked at me like, but it can't be better than lap with mesh. Like, but you're just adding more tools. Why not have more tools? That's like my, I don't know,
absolutely.
shtick, right?
And we should never feel that we've found the answer. I think for something as common as hernias are, I think we're going to look back 50 years from now and we're going to be amazed because we're going to have such better therapies. I just think that we're doing the best we can right now and we're much better than we used to be, but
Yeah,
we still have a long way to go.
yeah, I totally agree. In fact, I don't know, were you at the AHS? We had something called the Great Mesh debate, and we had every single, this was not an educational thing, it was kind of a fun part where it was not a like educational based, but we had these debates called the Great Mesh debate, and each surgeon had to promote their favorite mesh
Yeah.
and tell you, and then you debate like, well, yours shrinks more and yours encapsulates, whatever. And I ran that one for the first year. It was really fun. And the comment I made, which I stand by it, I think it was like 2006 or something, 5 or 6. The comment I made was, there's going to be a time when our grandchildren will look back and be like, you're putting plastic in people's bellies and you thought that was a good idea? Like, where'd that come from? And we're moving in that direction. And I think patients are pushing us in that direction too, especially patients who have been harmed by mesh products. Again, I feel like we need something besides human tissue to help us with hernia repairs, but we certainly don't have anything ideal yet.
No. And I think you're right. I think I've said the same joke. We're going to look back and say we
Yeah,
can't put plastic
yeah,
in people, but we don't have anything better. But I love that people are working on polymers. People are working
yeah.
on, I've seen such cool ideas and I listen to every one of them because I think that true innovation is going to show us a new way of doing it.
And I think bashing the companies is not adequate. We rely on these companies to come up with
Absolutely.
these polymers. There's no one surgeon or one human being that can like come up with this alone. You need a whole village of scientists and engineers and people
Yep.
who do this for a living. Yeah, I totally agree. We have a question. It's about a umbilical hernia after a lap appendectomy. You do a lot of lap appendectomies in children too, right?
Yep. Yep.
It's not necessarily open.
No, we do them lap. In
Yeah.
fact, we do them different than the adults there too.
What?
We do single port. So we just, because they're
Oh,
small, we
yes.
reach in and grab the appendix out through the belly button and remove it with a single incision. And we also, I don't know if you do this, but we send them home from the recovery room. So they don't stay overnight. But incisional hernias can happen
Yeah.
after. So when you're performing a laparoscopic operation, that you have to remove something like the gallbladder or the appendix, you
Right.
have to make a big enough incision in the belly button to get it out. And usually that's about 10 to 12 millimeters or about a centimeter.
Yeah.
And although we put stitches in there, certainly the stitch can break. They're usually a dissolvable stitch. They can dissolve too soon. And so you can get a defect or an incisional hernia at the umbilicus or at the belly button. And that, again, is just as easy as I told you before, that you just basically have to go put a couple stitches in there. Now, the difference is there could be some scar tissue to things stuck there,
Hmm.
like the intestines, but for the most part, it's putting in a few stitches. You shouldn't need to put mesh in a child.
How much of an issue is obesity in the hernia repairs that you perform?
It's becoming more and more of a problem.
Yeah.
And, that is most of the, babies are not very big. So that is unusual for us, but it's becoming more common. And those are certainly,
Teenagers are huge.
yep, they are. And that's, now we're getting into basically an adult sized patient and the dynamics change. And so That's a great question. What do I do if a 17-year-old morbidly obese teenager comes to me with a 5 centimeter umbilical defect? I probably would send that to an adult surgeon, to be honest with you,
Right.
because um, I, when I trained under general surgery, I did a lot of those operations, but haven't done them in a while. And I firmly believe, just same to the question that was asked earlier, is should pediatric surgeons do pediatric hernia repairs? I don't think pediatric surgeons should be doing adult hernia repairs. I think that we need to send those to our adult colleagues who, in general, in surgery, this is my philosophy. If there's someone who does more of them than you, that's who they should go to.
Right.
And
Right. That's
I
good.
frequently will refer patients away that I think I could do the operation, but there's someone in the same city that can do it better. I send them away.
I suspect Ohio has its fair share of obese teenagers.
Yep, we do.
On that note, do you think that their inguinal hernias should be done, like a 17-year-old that's 200 pounds, do you think that should be done by an adult surgeon, or is 16, 17 kind of your cutoff where if they look like an adult, you treat them more like an adult?
Great question. So again, this gets to the controversy of what is the chance of it coming back again? What is the risk tolerance of the patient and their family? So if we don't know yet what predicts recurrence. So because the number is so small, we would
Got
need a
it.
huge population to figure that out. Is obesity a predictor? Because remember, if it's a teenager that has a hernia, they almost certainly had that from birth, and it's probably a pediatric type of hernia where it's not a muscle problem, but the inner lining is still persistent that we need to remove that little tissue.
Right.
So even at that age and even at that size, they still probably have the same problem that can almost certainly be fixed by removing it. But I would have very little heartache telling the family, look, the way I do it is I would do a pediatric repair. I think the chances of it working are very high, but it may fail, and you might have to go to an adult surgeon. Most still choose to have it done, but I absolutely would give them the choice in the name of an adult surgeon.
Right. Right. Okay. That's fair. Uh, Next question has to do with the mesh again. So when do you ever use mesh, and when is it appropriate to use mesh? Are there situations where would you rather use like a biologic in children? I'm just
Right. Good
wondering
question.
when you would ever use it. And I'm thinking not only like a 1 or 2-year-old, but like a 10-year-old. What about a
Mhm.
16-year-old?
We do use mesh,
Yeah.
and it's not in the circumstances that you're probably thinking of because they're different diseases.
Okay.
But I will tell you this, that when we need it, sometimes we have to special order it because we don't keep much mesh in the hospital.
Uh,
But we do have mesh, and the most common example, sometimes babies are born, see, we see other types of hernias in kids. So babies are born with a hole in their diaphragm, the muscle between the abdomen and the chest.
right.
And we have to sometimes fix that because you can't get the edges together. We put a piece of
Oh,
vortex in there
okay.
to hold that. Now, you do run into the problem that when they grow, it could fail because that little thing doesn't hold it anymore as they get
Right.
bigger. But by that time, a lot of the tissue has ingrown, and we don't see many older patient recurrences. We do have uh, babies that are born with what are called abdominal wall defects. Some
Yeah.
babies are born, we just operated today on a patient uh, that they're born without their muscle being closed all the way in their abdomen. So their intestines are sometimes on the outside of the body, and they have a big hole.
This is like
And
a omphalocele or a
an
gastro.
omphalocele or a gastroschisis.
I did a
And
month of
what's
pediatrics.
that? Yeah, exactly. Yeah. So, and again, forgive me, but I think the most of the audiences are families, so I'm gonna use the non-medical terms, um, but so
Thank
the
you.
yeah, but these holes sometimes can be closed by us with stitches, but sometimes they can't be closed, and so we need to put in a mesh to hold it together. Now, your question about biologic. So
Yeah.
biologic mesh is a mesh that dissolves away over time. It absorbs away over time and can leave a little bit of a matrix to help tissue grow. But we have found that they don't work very well.
Mm.
And so
Same with
we
adults.
don't typically use biologics if we need to bridge something together we usually would use either a polypropylene, we would use or a Gore-Tex type mesh.
So maybe this hybrid mesh is of use. This kind of
Absolutely.
it's like 94% biologic or 96% biologic, 4% synthetic.
So that's
Like
why
darning.
I
Yeah.
like to go to your meetings. That's why I go to AHS. That's why I go to SAGES, because we have a lot to learn from the adult surgeons and the stuff that you guys are using and how we could use it in children.
Yeah, it's why I enjoy these sessions with you, and we have urologists and gynecologists, we have orthopedic surgeons all coming to these sessions. I learn from them, and I've learned from them in the past, and so I feel it's very useful. And I always like learning stuff. It's,
Yeah.
got to keep on learning. Okay, let's see. Oh, let's talk about athletes. It's a good question about athletes. This is a good one. Um, do young athletes ever get sports hernias, and how do you treat them?
All the
Or
time.
do you treat them?
No. Well, I treat them, but not with surgery usually.
Yeah.
So
Great question.
controversial topic. A sports
Yeah.
hernia is controversial in my opinion. It's not a true hernia. It's a
Mhm.
misnomer because it's basically ligamentous tears that are from sports, aggressive sports. Usually I will do 6 to 8 weeks of physical therapy and rest. Here's the worst part. Who gets a sports hernia? The good athletes. So the worst thing you could ever tell them is you have to take a season out from sports. But,
Right.
if they want it to get better, that's what they have to do. It's probably not dangerous, but it will continue to hurt until they take a good 6 to 8 weeks of rest and physical therapy. There are some surgeons who believe in doing a mesh repair on those, a lay mesh to cause scarring. I don't, but I'm sure some do.
I agree. No, there's that, and also, what about do you have doctors, either general surgeons or sports surgeons, orthopedic surgeons, that do, releases, muscle releases? Probably not. It's in a child, in a
Oh, I've
teenager.
not seen that. No.
Yeah, probably not. They just have to heal.
Yeah.
Yeah. What other topics have we
So
missed?
let me rapid fire through here. So
Yeah.
common things, another one is epigastric hernia. That's
All
a
right.
small defect in the top of the abdomen. That's controversial. I used to fix them all. A lot of surgeons are now trending towards not fixing those
Mm-hmm.
because they're more cosmetic. They can cause problem when they get older and they get bigger. So some would fix it now for the same reason that we fix belly button hernias, because they could be harder to repair in adulthood. But a lot of surgeons, including myself, say if it's not bothering you, you have the option of just leaving them alone. So that's epigastric hernias. That's a little tiny hernia in the upper abdomen that's only a partial hernia, not the full thickness of the abdominal wall, just the fat pokes through.
Yes.
The other things to talk about is what do we do if we find a hole? You sort of alluded to this earlier when we're doing another operation. So I don't usually fix those because I think a lot of us have those holes and they never cause a problem our whole life. So if we find a hole when I'm doing another operation, we let the parents know about it, that it could become a problem, and the other stuff might go down that hole, and they should get a repair at that time. But I don't usually fix it at that time. Some do fix it, so it depends on your surgeon. Another common question is that when we go to fix one hernia, 20% of the time in children, they have a hernia on the other side as well.
Yes.
I give that choice to the parents, but because I do it laparoscopic, I'm in there, and most parents have asked to fix both sides. So that's another controversial point.
I remember videos where they would stick a camera through one hernia to look for another hernia. They still
Correct.
do that?
Those who do open hernias still do
Uh-huh.
that. But I don't do it because I do it lap. So I just go in, I see both and fix them.
Yeah.
A hydrocele. A hydrocele is a type of hernia where the hole closed almost all the way after the testicle went down, but it didn't close all the way. So there's a microscopic little hole. So just enough that fluid can get inside, but not intestines. And so those are not dangerous. They actually are only really a cosmetic problem. Some wonder if the bathing fluid could cause a fertility issue. That is, we do fix those, but we wait till they're older to fix those because there's not an urgency, and most go away on their own. So you might.
That's like those are like roof leaks, you can't really see that hole, but then the water kind of eventually makes
Yeah,
its way
it
through.
just
You
the
see a
same
little
exact,
drip, drip, drip. Yeah.
just an annoying leak.
Yeah.
Yes.
Talk to me about undescended testicle.
Yep.
Because in adults, it's not normal for the testicle to rise up into the groin, but when it does, we should always look for an occult hernia as part of the reason for it.
Yep.
In children, you always look for undescended testes. Is
Yep.
that an association with hernia or no?
It is. It is. And it's a challenge because normally, as I said, the testicles go down and down into the scrotum. And when that doesn't go just right, sometimes they get stuck. They didn't go all the way down. And that's a problem because the reason the testicles go down into the scrotum is because they need to be cooled down there. And so if the testicle stays up high by the abdomen, it can cause infertility, and it
Yeah.
can even have a slight increased risk of cancer. So for that reason, we like to bring the testicles down into the scrotum so that we can evaluate them and examine them throughout their life to make sure that they don't get a lesion there, and also to maintain fertility. We do those by about 6 months to a year of age. We fix those, but a lot of those, when they're born with a high testicle, you wait and they come down.
Oh, they do come down. Do you
Yeah,
just
yeah,
have
most come down. So we see them when they're babies. We wait, and they just retract down over time. By the
do
time
you
you see
have
them,
the parents constantly like pulling on it or
I
confirm
don't
that
do
it
that.
stays down?
No, we just examine them. At period. What I actually have them do is have them come back and see me at 6 months and a year because that's when we'll fix it. There's no reason to come back sooner
Right.
because I won't do anything. And a lot of places the urologists do that. Pediatric surgeons or urologists do it. There's a common another situation that's called a retractile testicle, which doesn't need surgery, and that's just that the testicles are so small in a baby that the muscle's too strong and it pulls it up. But if you
Oh,
actually pull the testicle, you can easily pull it down. So you don't need to do anything. When they get a little bigger, the testicles will fall normally.
that's too cute. So in adults, we believe that inguinal hernias, actually all hernias, but mostly inguinal hernias are genetic. So if you have a family history of, your parents, siblings, uh, aunts and uncles have hernias, then you're more likely to have hernias. We feel it's a collagen deficit. And what I learned in my practice, because I see a lot of women, it's about 50% women, where if I saw everyone equally, I should probably see about a 10-to-1 ratio of males to females, but I'm about 50-50. What I've learned is, because I ask about family history in everyone, is that if they have a mother or sister or female in the family with a hernia, that genetic link seems to be much stronger. And then I saw a pediatric study. It was a pediatric study done maybe like 3 years ago that looked at family genetics and said in children, the female genetic lineage is much stronger in passing on so little kids are more likely to have hernias if their mom had a hernia than if their dad did.
That's
That's pretty
interesting.
cool.
That's very cool. I will tell you, there's absolutely a congenital nature to it, but it doesn't follow the exact lines of genetic distribution that you would think with a true autosomal dominant or autosomal recessive trait. But there's absolutely a familial component to hernias.
Yeah. And you see a lot of children with hiatal hernias. Is
Mhm.
that linked? Do you see them also having other abdominal wall hernias or no?
Great question. I don't know the answer to that. I don't know if there's an association, also, although there may be. I think the physiology, the pathophysiology is a little different.
Oh, it's different.
But the yes, a hiatal hernia is absolutely something we see in kids, and it's very common. Just like the inguinals, it's much, much, much more common in the newborns. That's who,
Yeah.
as we all know, newborn babies vomit all the time. And so you can imagine that's because they have really big hiatal hernias that get better with time. So we try not to operate on those, but eventually sometimes we have to if they can't feed.
Man, I remember in my pediatric surgery rotations, we were lucky because we had at UCLA, we didn't have a pediatric surgery fellowship. So as residents, you were it, and we did these amazing operations. Eric Funkelsrud was
Yeah.
practicing, and he's just an amazing guy. And we learned a lot. But and there was so many hiatal hernias that we were repairing. Not as many inguinals and stuff. It was all hiatals. I swear to God, I would walk down the malls and I would see kids. I'm like, I'll bet you every single one of you has a G tube, and you're
That's
cute, but I'm sure behind that cute little outfit there's a G tube, because it just seemed like every kid had a hiatal hernia.
that pendulum has swung and it goes back and forth. Right now, it's in the era of we shouldn't do as many. I was trained in one of the highest centers that did hiatal hernias, but we have really backed away from that
Got
recently.
it. Got it. What is there's a question about a rouge hernia mesh. Have you heard of that?
I don't.
Rouge? I've never heard of that.
I'm sorry. Yeah, but we don't use much mesh, so I'm not a mesh
Yeah,
expert.
yeah,
Yeah.
exactly. So do you see patients outside of your area? And if you do, what's the process for out of town patients to come see you?
Yeah, so I get, interestingly, a lot of the calls I get from out of town, I'll just be totally honest with you. I would love for every patient to come see me, but you probably don't need to. I think that the beauty about inguinal hernias is that it's a relatively straightforward operation, and I am sure that there are fantastic surgeons in your location that do the operation. And if you ever need, if you ever have a question, go ahead and email me, and I can connect you with someone in your area. It's tponsky@gmail. That's just email me and I can find someone in your area. Now, who does come to me are what I get calls about are adult or older patients or adolescents
Yeah,
that want to have the laparoscopic non-mesh hernia repair. If there's no one in your area that does the laparoscopic repair, um, here's my answer. Definitely get a hold of me and we can do the operation. But you know what? An open repair is pretty good too.
right.
So I would say that if your surgeon only does it open, that's fine. I don't
Yeah,
think
don't force that surgeon to do a laparoscopic for sure.
no, and you probably don't need to travel either. I would go with what your surgeon has. There's pros and cons. I think if your surgeon does it open, that's fine. So, yeah.
Yeah, I totally agree with that. I must say you have been very helpful. I do what's called online consultations for patients, and every so often I get, a mother that emails me and says, I read about these stories about your patients, and it sounds like my child. And but my it's a child. I'm an adult
Yep.
surgeon. So if it sounds like something I can help, which is abdominal wall related, or so, if I can help in any way, I try and help. And I've reached out to you a couple of times, and you've been super, super helpful. And the patients, they just need some direction, and they need to trust someone. And for you to be so open and available, and your team was so available, your assistant was so nice to be able to reach out. You guys directly reached out to these people you don't even know based on just my questioning, and they got the treatment that they needed. And for a mother and seeing their child suffer like severe pain or not eating because of different abdominal issues, it really means a lot. And I think that's why I go into pediatric surgery, because you can help so much. Um, but so thank you for your time, for
Thank
devoting
you.
for this, and all the questions have been answered, and I learned a lot. I'm glad I can see you during this COVID time.
Yeah.
But please do know that besides what you do in your hospital with your own patients, you have helped a lot of people outside as well. And
Very nice of you.
um, I myself have had multiple times when I've reached out to you. You've always been helpful. So thank you very much.
Thank you so much. This has been wonderful. Thank you.
Thank you. So for everyone, that's the end of Hernia Talk today. I will post the entire session on YouTube and share that on all our different social media platforms. You can follow Dr. Ponsky on Twitter at @tponsky, and he also shared his email address with you all. I will see you all next week. Thank you very much, and have a great rest of your day. Thank you very much.
Thank
Bye.
you.
Thank you.